I'm going to talk today about the treatment of Lennox-Gastaut syndrome. I'm Zach Grinspan. I'm the Director of Pediatric Epilepsy at Weill Cornell Medicine. These are my disclosures. I did want to just start with a shout out for an organization and an initiative that I'm leading called the Pediatric Epilepsy Learning Health System. Still learning how to summarize it in a few words and not many. But our mission is to reduce seizures and their consequences for children with epilepsy through cycles of health data collection and analysis, dissemination of new evidence, and practice change. And our vision is that all children with epilepsy receive timely and optimal care according to standards that are continuously improved. I am not doing this alone. I've been very lucky. I sometimes feel like I'm a sapling in a forest full of redwoods, that I've had the really wonderful opportunity to work with some of the leaders in the field, and I have learned a tremendous amount of that, from them, and I'm greatly appreciative of their mentorship and friendship. So Ann Berg and Jeff Buchalter, who are here, are part of our leadership core, as are Anu Patel in Columbus and Renee Shalhas in Ann Arbor, Michigan. So today I'm here to talk about treatment for treatment-resistant epilepsy, treatment for the Lennox-Gastaut syndrome. And as I thought about how to frame this, how to think about it, I put together this diagram that kind of maps out the trajectory, the sort of the story of children and adults who have intractable epilepsy. So you're born, and you don't have seizures until you do. And then there's the first seizure, and we don't call that epilepsy yet. But then you have the second seizure, and we say, okay, now you have epilepsy. So at that point, we're using our early drugs, is what I call them. So then the first one fails, the seizures continue, and then the second one fails. And then you become treatment resistant. So that word, that term means that two medicines at adequate doses have not controlled the seizures. And then we start using our later drugs, for lack of a better term. At the same time, if you're at an epilepsy center and you have an epilepsy doctor working with you, often you start to think about other therapies, things like diet, devices, and surgery. So I want to talk about each of these today. Let's start with the drugs. So this slide communicates something that apparently happened in many of the talks yesterday. We have so many drugs. We have lots and lots of drugs, lots of choices. Each one has its side effects. Each one has its different mechanisms. They work at the synapse before the neurotransmitter release. They work after the neurotransmitter release. They work on different channels. And depending on who you talk to, different people will categorize these in different ways. For this talk, I thought to try to simplify this a little bit, I would think about, well, what seizures are you treating with the medicine? And that at least I can bucket into three groups. There's medicines that work for focal seizures. Those are seizures that happen in one part of the brain and often are associated with motor movements or brief transient loss of consciousness. Absent seizures, those are the staring spells. And then there are other medicines that sort of seem to work for everything. Within those focal medicines, you've got medicines that specifically work on sodium channel blockers. The reason I call those out is that those are some of our oldest and most well-understood drugs. And often you sort of hear people talk about like, oh, we'll try a sodium channel blocker. And I wanted to demystify that a little. And then there are a couple of other drugs that have different mechanisms. And then within the any group, the ones that work for anything, the benzodiazepines and barbiturates, again, because it's an older class, phenobarbital we've had for 100 years. So I sort of think about those in their own group. And then there's a bunch of other medicines that work in a variety of ways. So here are the early drugs, and there's still too many on these to go through all in detail. But for the focal epilepsies, we've got carbamazepine, oxcarbazepine, and lacosamide. For absence, ethosuximide, which we know works very well. And then in the benzos and barbiturates, we have clobazam and phenobarbital. And then the other ones, levetiracetam, valproic acid, zonisamide, topiramate, lamotrigine. So in my office, these are typically the ones I'm thinking about when a patient first comes to me. And we're talking about either the first medicine or the second. Often the third will often come from this list. So then there's a later group. It's not necessarily that these are worse or that they have, or that we know less about them in some cases, but they're often newer. The side effects are sometimes more intolerable. They're harder to get. They require more paperwork. They're expensive in some cases. But they can all be valuable in their own for certain patients. So for the sodium channel blockers, eslicarbazepine and phenytoin. For the others, I put gabapentin and pregabalin. Ethosuximide has a cousin, methsuximide. In the barbiturates, clonazepam, clorazepate, diazepam, primidone. And then stiripentol isn't really a barbiturate, but it works in the same, or it isn't really a benzodiazepine, but it works in a similar mechanism. And then there's the others, brivaracetam, felbamate, rafinamide, parampamil, and cannabidiol, which is the most recent one. I always feel like it's alphabet soup when I talk about these, but I did want to sort of try to conceptualize these. And then there is a kitchen sink. There are other medicines that are out there that people talk about that are used more rarely. Acetazolamide is a drug that's been around for a long time, and some of my senior professors loved it. I've never used it, but people talk highly about it. I've heard amantadine starting to be used, and then bromide, again, a 100-plus-year-old medicine that can be very effective when used, but can be challenging to get hold of. One of the exciting things about medicines, and Dr. Koh and Dr. Sheffer mentioned this morning, is that increasingly, if we know the gene, it helps us pick the drug. So here are some examples. GLUT1 deficiency, actually it's not a drug. We would use the ketogenic diet. There's a rare disorder called pyridoxine dependence caused by mutations in antiquidin. And you just give a vitamin. You give B6 and sometimes another vitamin, folinic acid, and that can control the seizures. Dravet syndrome, SCN1A, stiripentol, and clobazam seem to be particularly good. There's a disorder called Alpers-Huttenlocher disorder associated with POLG1. And you don't want to give those children valproic acid. I was talking, I'm forgetting his last name, Dr. Michael yesterday, there he is, who was saying that he had a patient who was well controlled on valproic acid for like 15 years, and then he did genetic testing and he had this gene. So these rules, unfortunately, need to be taken with a grain of salt because children don't read textbooks. There are some immune-related variants that tell you to avoid carbamazepine because of the rash. Tuberous sclerosis, vigabatrin is particularly good for infantile spasms, and then there's some specific medicines of everolimus, sirolimus. KCNQ2 seems to respond well to sodium channel blockers. SCN2A and 8A seem to maybe respond to high-dose phenytoin. And then there's some emerging evidence about calcium channel blockers and calcium channel and ABCB1 polymorphisms in childhood absence, and then some controversy about quinidine for KCNT1. I worry that I narrated this list and bored you, but the point that I wanted to make with this slide was that increasingly we're learning how to link genes with treatment, and so the more we learn about these specific genes, the more we see what patients are responding to and not responding to, the more we contribute our data to these registries. The signals sometimes come up, and then we get some idea of what to do, which we can then test in trials. I put this slide twice. Okay. So other things with medicines, we talk a lot about rescue medicines. I like two, depending on how old you are. Rectal diazepam is sort of our classic. This is the medicine you give when your child is actively seizing and you want it to stop. The other medicine for that is clonazepam, and I give this sometimes to older kids. Giving a rectal medicine can be embarrassing to do in public sometimes, and oral clonazepam also can be effective at stopping seizures in their tracks. So of the medicines that I've talked about, which one is the best? We don't know. It's actually, we have all these medicines, but as Dr. Berg often says, we practice in an evidence-free zone. We don't really know a lot about the comparative effectiveness of many of our meds. On one of my earlier slides, you see that clobazam ends up in my first. It's one of the earlier drugs that I use. That's largely because of this figure. Somebody took all of the effects in the trials and just put them all in the same graph. Now, this is not a comparative effectiveness trial. There wasn't some group of kids, and some kids got lamotrigine and some kids got clobazam. So the populations are very different, and this data is in many ways deeply flawed. But this blue bar, which says how many kids, what was the median reduction in seizure frequency, is like between 60 and 70% compared to this little gray bar of placebo, which is less than 10%. And that dark blue bar is a lot taller than the light blue bar, the green, the yellow, and the red. So for me, and then also with clinical experience with people talking about their successes with clobazam, I end up using this a lot. For comparison, the cannabidiol, which is very exciting, and the more medicines we have, the better. The cannabidiol, this is from their publication, seems to be the closest to this summary graph. Seems to sort of work similarly to lamotrigine, rafinamide, felbamate, maybe a little better than topiramate. So I use I haven't given cannabidiol yet, although my colleagues are writing it quite a bit. But it does work, but I put it in that second bucket of meds. A couple principles of therapy, like why are we making the decisions that we make about which medicine to use? I think the most important principle of therapy is that it's a conversation. What I typically do with families is, with the first seizure, with the second seizure, with the first med, second med, is I say, all right, here's some choices. Here are the side effects. Here's how often you have to take it. Here are things you have to watch. Here are things you don't have to worry about. And I often will give 2, 3, 4 different medications, and then if we have to choose at that minute because we're nervous that the seizures are really out of control, then we'll make a decision fast. But often families will take a few days and think about it, do some reading. And my goal as a doctor is to make sure that the child is getting a medicine that is getting the medicine every day. And so my hidden agenda is that when we're all in agreement, when we're all aligned, my ultimate goal of making sure the child is getting the medicine every day is more likely to happen. So those conversations I find to be critical. I think many of us err on the side of titrating the medicine up slowly if we can get away with it. I mean, if a kid is having seizures all the time, you have to go fast. The reason to go slow is that often we're going up into the point of side effects, and you really want to know when those side effects start to hit. And then you also don't want a family to say the side effects are worse than the disease, and I'm sick of this medicine. So if you go slowly, we often have better luck of finding the right medicine with either no side effects or tolerable ones, which is my third point, to pay attention to side effects. I try to maximize one medicine before starting another, and part of it is we all sort of work by anecdote. I had one child who had a community physician who had this idea, well, I'll start a little bit of drug X, a little bit of drug Y, and the child had a terrible allergic reaction, ended up in our burn center. And so I try to just keep, one thing at a time, because every time you're introducing a new medicine, there's a risk of anaphylaxis and skin reactions, things like that. I try, again, to change one thing at a time. Again, you cannot always do this, but this way you know what's working. And then treatment resistance, as I said before, is failure of those two medicines. If after two medicines the child is still having seizures, you have to move on. And it's a conversation. Families aren't always ready for diet devices and surgeries, but you have to start having those conversations early after seizures continue with that second medicine. And then if you get to 2 years without seizure freedom, then you're having the other conversation, which is maybe we should start pulling these drugs off. Maybe it's time to start thinking about coming off. And those can often be difficult conversations because seizures are so scary, and they can, and families are often reluctant to come off. And then the final thing I wanted to say here is that there's often good reasons to ignore everything I just said. Every patient is different. Every child has their own story. And the physician community often has different experiences. And so, in that conversation, sometimes you're like, yeah, I'm not going to do what the textbook says because in this case, we have to do something different. Few other words, rational polytherapy. We kind of think like, well, X and Y are going to work better than X and Z. The best data we have is valproic acid and lamotrigine. We've got a couple of good papers that say that those two in combination seem to have some synergy, and there's some animal data to back that up. I didn't mention steroids. Many of us use steroids. They often seem to work. They kind of quiet kids down. The data on this is actually lacking. and I think is a really important gap in our understanding of our therapies. There's this consensus paper. It's 10 years old now, but what's written in there I want to read because I think that it still holds true today. Everyday practice, they write, suggests that steroids may occasionally have a major effect, and I think many of the clinicians have seen that, particularly for the control of atypical absences, drop attacks, and prolonged episodes of non-convulsive status. However, no controlled study of steroids is available as yet, and relapse seems common. So we're sort of stuck in this, again, evidence-free zone. It's like, well, everyone says that it works, so we can try it, but then how long do you keep it on? What dose do you use? How long do you, and when do you abandon it? So, okay, so we talked about medications. Let's talk about everything else. So diet, devices, surgery. Let me talk about surgery. So let me start this conversation just by saying why do we even talk about surgery? I mean, operating on a child's brain, that's like a big deal. We're going to open your head, we're going to take out part of your brain. That's the seat of the soul. That's where your personality is. It's where all your sort of like where you are. So this is like a big deal. Why are we so passionate about it? When you look at the literature, you often see graphs like this. So higher is better. The x-axis here is time. And this is a group from India where they had children who had treatment-resistant epilepsy and who they thought they had a decent surgical plan. On some of them, they waited a year before they did the surgery, and on the other ones, they did the surgery right away. And they randomized. So the red line are the children who did not get surgery. And what you see is that, when they start, none of them had broken through seizures, but by 1 month, only 20% were seizure-free, and by 6 months, all of the children in that group were still having seizures. Conversely, in blue here, this is what happened with the kids who got the surgery, and you can see this dramatic difference between their degree of seizure freedom versus the medical group. In their study, at the end, about 40% of their children were still seizure-free, but if you think about that compared to none, that's sort of what gets us up in the morning. That's why many of us are very passionate about trying to do the surgical workup as soon as possible. And then, as I put up this slide, I realized that 40% maybe didn't sound that good. So there's other series that have better outcomes. This is a series from a Korean group where they had 60% seizure freedom in their group. So it often depends on the details of the child. Another principle about epilepsy surgery, earlier is better. In this series, children who were under 5 and had epilepsy surgery, 80% of them were seizure-free. By the time you got into 5 to 10, it dropped down to about 40%. So again, I think I heard that yesterday there was a conversation about what does it mean to be aggressive. So in my mind, aggressive is let's do the surgical workup, let's get the scans, let's bring to conference and figure out if there's a surgical option here. How do you evaluate for epilepsy? 3 minutes. Okay, I will do this slide and then I'll end. So evaluating for epilepsy surgery. So there's sort of 2 flavors of epilepsy surgery. There's the resection, where we actually have something that we can take out, or ablation, where you can zap it. Or we have palliative, where you've got corpus callosotomy, which means that you cut the information superhighway between the 2 sides of the brain, the corpus callosum. Or you can do devices like vagal nerve stimulator or RNS or even DBS. RNS is responsive neurostimulation, and DBS is deep brain stimulation. So here's what you do. First, you want to know, is there a seizure focus? Is there something, are there seizures coming from one place or a few limited places? And so that's what the EEGs are for, and that's what your first MRI is for. If you think there is one, then you really want to be sure. So then you do your PET scan, your SPECT scan, and your MEG. The idea is you're getting corroborating evidence, additional pieces of data that say, yeah, That's where the seizures are coming from on the EEG and the MRI and these other studies. And then when they all agree, then you get a bunch of smart people in a room at our epilepsy conference and say, is there a compelling enough story that we should chase this? So if it's true that you have a seizure focus and you're pretty sure about it, what's going to happen if you take it out? What's going to happen to cognition? What's going to happen to language? And what's going to happen to motor control? So that's what your functional MRI is for, a WADA where you put half of the brain to sleep and then see how the other half does, and neuropsychiatric testing. If everything is a go and you sit down with a family and you say, here are the risks and benefits of trying to go after the surgical focus, the epilepsy focus surgically, then you do your surgery. If anywhere along this route and the seizures are intractable and you're willing to do a surgery, then you're looking at corpus callosotomy or devices. I just got 5 extra minutes. Okay, so Tracy's the best. I'm so happy to be here. I had a lovely flight. No, sorry. Okay, great. So I had a bunch more slides that I'll now go through. So I'll go through these quickly just as a sort of an overview of these other things. So what is epilepsy surgery? You have lobectomy and lesionectomy. That's where there's something in there and you just kind of take it out. You open up the skull, the neurosurgeons go in there, and they cut out a piece of brain. You have hemispherotomy. There was a picture earlier of a hemispherectomy where you take half of the brain out. We don't do that anymore. You just disconnect that half of the brain, but you leave it in. So that's a hemispherotomy. There's this idea of one-stage surgery versus two-stage surgery. Sometimes you're so sure where the lesion is, you just take it out. You open it up, you go after it, and you take it out, and you're done. Sometimes you're not that sure. Most of the time, you're not that sure. So then you do 2 operations. The first one is you do something to figure out exactly where the seizures are coming from, and then you take it out. So that phase 2, where you're really trying to figure it out, comes in 2 flavors. You can do grids and strips. You open up the skull, you lay on some electrodes, you put the skull back, you wake up the child or the adult, and then you watch them for several days, and you watch their seizures. You see where they're coming from. And what's lovely about that is that often you can draw on a slide where the epilepsy focus is. So in this picture, that red filled-in area is where the lesion is. The other thing we do is called stereo EEG, where you don't open up the skull, you just drill holes in the head, and you put little electrodes into the head, into the brain to see where the seizures are coming from. And this is sort of the modern way to do this, and it can be very effective at identifying the seizure focus. Sometimes you don't want to open up the skull, and so you can do ablation, either with a laser or with focused ultrasound. And then if those don't work and you still want to do a surgery, then the corpus callosotomy. Let's see, devices, there's vagal nerve stimulator, which works. I usually quote about 40%. It's rare for vagal nerve stimulators to make you seizure-free, but about 40% of the time you get a significant reduction. Comparing vagal nerve stimulator versus corpus callosotomy, they're both really good. Corpus callosotomy is better for drops. But for other kinds of seizures, they're more or less equally effective. RNS is cool because it detects the seizures and then zaps them while they're happening. And then deep brain stimulation is newer. It's been used for other disorders, but it can be quite effective. And then finally, diet, and I'll end quickly. There are all these lovely dietary therapies. The classic one is the ketogenic diet. The ketogenic diet is hard. It's like a shake of heavy cream for breakfast and all of these high-fat things, but there are some more tolerable versions of it where you can add a little bit more of carbohydrate or protein, the medium-chain triglyceride, modified Atkins, and low glycemic index. And those can work often, again, 40-50% of the time. Okay, I did my slides. Tracy gave me an extra 5 minutes, which I'm grateful for. So thank you all for coming. Thank you for listening. I'm around after through lunch, and thank you again.